So to continue with multiple organ dysfunction syndrome on page 755, multiple organ dysfunction syndrome occurs due to the sequence of cell damage caused by the massive release of toxic metabolites and enzymes. Once the damage has started, the sequence becomes a vicious cycle as more dead cells open and release metabolites. They trigger small clots, microthrombi, to form, which block tissue perfusion and damage more cells, continuing a devastating cycle. Liver, heart, brain, and kidney functions are lost first. The most profound change is damage to the heart muscle. Signs are a rapid loss of consciousness, non-palpable pulse, cold, dusky extremities, slow, shallow respirations, and unmeasurable oxygen saturation. Therapy, included fluid replacement, is not effective in saving the patient's life, even if the cause of shock is corrected and mean arterial pressure temporarily returns to normal. Under etiology on page 755, your text provides a nice definition for hypovolemic shock. It states hypovolemic shock occurs when too little circulating blood volume causes a mean arterial pressure decrease that prevents total body perfusion and adequate gas exchange. Hypovolemic shock from hemorrhage is common after trauma or surgery. Hemorrhage leading to hypovolemia can also be caused by any problem that reduces the levels of clotting factors. Hypovolemia from dehydration can be caused by any problem that decreases fluid intake or increases fluid loss. Recognizing hypovolemic shock is a major nursing responsibility. We need to identify patients at risk for dehydration and assess for early signs and symptoms. This is especially important for those who have reduced cognition or mobility or who are on NPO status. Assess all patients with invasive procedures or trauma for obvious or occult bleeding from impaired clotting. Compare pulse quality and rate with baseline. Compare urine output, vital signs with baseline. Check vital signs for patients who have persistent thirst. Assess for shock in any patient who develops a change in mental status, an increase in pain, or an increase in anxiety. Stress the importance of seeking immediate help for obvious heavy bleeding, persistent thirst, decreased urine output, lightheadedness, or a sense of impending doom. I'm going to have you look at the assessment noticing section and also the interpreting and responding sections on your own. When you're looking over the assessment noticing and the signs and symptoms, think back to what the problem is and why it makes sense that you're seeing the response in the patient that you're seeing. Also, when looking at the responding section where it talks about how we manage these problems, again, think about what the initial problem is with the patient and how the interventions address that problem. And be sure to pay attention to the small drug therapy chart 37.4, as well as any yellow boxes or any other charts within that section. So we're going to fast forward then to septic shock. Sepsis leading to septic shock is a complex type of distributive shock. So of the 4 types of shock, septic shock is a type of distributive shock. It usually begins as a bacterial or fungal infection and progresses to a critical emergency over a period of days. Figure 37.2 is a chart of the progression of sepsis to septic shock. As progression occurs, the pathologic problems occur faster and to a greater degree. Thus, control of sepsis and prevention of severe sepsis and septic shock are easier to achieve early in the process. Failure to recognize and intervene in early sepsis is a major factor for progression to septic shock. When infection is confined to a local area, it should not lead to sepsis and shock. Sepsis is defined as a life-threatening organ dysfunction resulting from a dysregulated host response to infection. It occurs as the presence of infection with systemic signs and symptoms. Infectious organisms have entered the bloodstream with sepsis. As their number increases, widespread inflammation, known as systemic inflammatory response syndrome or SIRS, is triggered as a result of the infection escaping local control. When organisms and their toxins in the in the bloodstream with organisms and their toxins in the bloodstreams and entering other body areas, inflammation becomes an enemy, leading to extensive hormonal, tissue, and vascular changes and oxidative stress, and further impair gas exchange and tissue perfusion. The white blood cells produce many pro-inflammatory cytokines. There is widespread vasodilation and blood pooling, allowing stasis. The patient has mild hypotension and a low urine output and an increased respiratory rate. These responses result in a hypodynamic state with decreased cardiac output. Some patients have a low-grade fever and others have a high fever. Still others may have a below normal body temperature. Fever and hypotension result from SIRS. The reduced urine output and increased respiratory rate are the compensatory responses to the impaired gas exchange and perfusion. Often the patient has the elevated white blood cell count expected with a systemic infection. Inappropriate clotting with microthrombi forming in some organ capillaries causes hypoxia and reduces organ function. The problem can be hard to detect, but if sepsis is stopped at this point, the organ damage is reversible. The microthrombi increase hypoxic conditions, which then generate more toxic metabolites. These damage more cells and increase the production of pro-inflammatory cytokines, leading to the amplification of SIRS and a vicious repeating cycle of poor gas exchange and perfusion. Although these signs are subtle, they indicate sepsis and SIRS. Unfortunately, this early hemodynamic state has a relatively short duration, and indicators are so subtle that the condition is often missed or misdiagnosed. When early sepsis and SIRS are identified and treated aggressively at this stage, the cycle of progression is stopped and the outcome is good. When sepsis and SIRS are not identified and treated at this stage, they progress and become much harder to control. Monitor the patient at risk for sepsis to recognize symptoms to meet the criteria for sepsis and SIRS. If any of these are present, respond by notifying the healthcare provider or the rapid response team. Note Table 37-3, sepsis with SIRS criteria, and Table 37-4, conditions predisposing to sepsis and septic shock. For Table 37-3, the sepsis with SIRS criteria, a lot of times in the hospital setting, you will have a checkbox that has this information, which causes or encourages nurses to evaluate patients to see if they meet the criteria for sepsis, and it sort of flags the patient so they can receive early interventions. So continuing with 762, when SIRS becomes amplified, all tissues are involved and are hypoxic to some degree. Microthrombi formation is widespread, with the clots forming where they are not needed. This process uses up many of the available platelets and clotting factors, a condition known as disseminated intravascular coagulation, or DIC. The amplified SIRS and cytokine release increase capillary leakiness, injure cells, and increase cell metabolism. Anaerobic metabolism continues and cell uptake of oxygen is poor. The continued stress response triggers the continued release of glucose from the liver and causes hyperglycemia. The more severe the response, the higher the blood glucose level. Despite the severity of this stage and the fact that it may be present for 24 hours or more, it is often missed. One of the reasons it may be missed is that the cardiac function is hyperdynamic in this phase. The pooling of blood and the widespread capillary leak stimulate the heart, and cardiac output is increased with a more rapid heart rate and an elevated systolic blood pressure. In addition, the patient's extremities may feel warm, and there is little to no cyanosis. Even though the patient may look better, the pathologic changes occurring at the tissue level are serious and have caused significant damage. The white blood cell count at this time may no longer be elevated because prolonged sepsis may have exceeded the bone marrow's ability to keep producing and releasing new mature neutrophils and other white blood cells. The white blood cell count may be extremely low, especially segmented neutrophils. Signs and symptoms include a lower oxygen saturation, rapid respiratory rate, decreased to absent urine output, and a change in the patient's cognition and affect. At this point, the downhill course leading to septic shock is extremely rapid. In terms of septic shock is sepsis-induced hypotension persisting despite adequate fluid resuscitation. It is the stage of sepsis and SIRS where multi-organ dysfunction syndrome with organ failure is evident and poor clotting with uncontrolled bleeding occurs. Even with appropriate intervention, the death rate among patients in this stage of sepsis is very high. Severe hypovolemic shock and hypodynamic cardiac function are also present as a result of an inability of the blood to clot because the platelets and clotting factors were consumed earlier. Vasodilation and capillary leak continue from vascular endothelial cell disruption, and cardiac contractility is poor from cellular ischemia. The major cause of sepsis is a bacterial infection that escapes local control. People especially at risk for sepsis are those who have reduced immunity and those who have central lines. Central lines in place, even for short periods of time, create a potential direct access point for microorganisms and can lead to central line associated bloodstream infections. Under health promotion and maintenance, prevention is the best management strategy. Prevention is the best management strategy for sepsis and septic shock. Evaluate all patients for their risk for sepsis, especially older adults. Use aseptic technique during invasive procedures and when working with non-intact skin and mucous membranes in patients with reduced immunity. Remove indwelling urinary catheters and IV access lines as soon as they are no longer needed. Ensure that patients receiving mechanical ventilation are weaned from the ventilator as soon as possible. Early detection of sepsis before progression to septic shock is a major nursing responsibility. The nurse is the healthcare professional most in contact with the patient and is in a unique position to detect subtle changes in appearance and behavior that can indicate sepsis. Use the assessment technique described earlier for changes in vital signs, lab findings, appearance, and behavior to identify early any characteristics of sepsis and sepsis progression at least every shift for potentially infected, seriously ill patients. Early detection can be made by patients and families as well as healthcare providers. Teach patients and families the signs and symptoms of local infection, such as redness, pain, swelling, purulent drainage, loss of function, and early sepsis, such as fever, urine output less than intake, and lightheadedness. Teach them to how to use a thermometer and to take the temperature twice daily and whenever they are not feeling well. Urge those with symptoms of early sepsis to immediately contact their healthcare provider. Teach them that if antibiotics are prescribed, to take the drugs as prescribed and to complete the entire course. I'm going to have you look over the next sections, assessment, analysis, and planning and implementation on your own. Again, make sure you pay attention to any charts that may be in those sections, and we will discuss those when we meet next week. If you want to also complete the end of the PowerPoint questions for both the burn section and the shock section, we will review those also when we meet next week.